Okay, let's unpack this. Welcome to the deep dive, where we really dig into complex info and pull out the knowledge that matters, custom fit for you. Today, we're diving into a world that's literally right under our noses and often on our tongues, too.
Yeah.
The fascinating and honestly often overlooked world of smell and taste.
Hmm.
These aren't just about, enjoying your coffee or a good meal.
Not at all.
They are vital links to our health, our environment, even our survival.
Absolutely crucial.
We're pulling our insights today entirely from one specific source. It's a really detailed text looking at the cardinal manifestations of diseases. And our focus, specifically Chapter 33, it really delves into the intricate anatomy, the physiology, the disorders, how we evaluate them, and the treatments for smell and taste.
That's right.
Everything we talk about today, every single detail is coming straight from this one chapter. It's our pathway to really getting a handle on this topic, aiming for mastery. Our mission is, well, straightforward but deep. Explore the basic biology, how these senses work, then uncover the, myriad ways they can go wrong, disease, other factors, understand how doctors figure these issues out, the tools they use,
Yeah, the evaluation process.
and look at the current ways we approach treatment. We're really aiming for a level of detail here that lets you feel truly informed, like the professionals who work with this stuff every day.
And that's so important because, like you said, the significance goes way beyond just pleasure. These senses are truly vital monitors. There are early warning systems for danger.
Like fire or gas.
Exactly. Fire, gas leaks, spoiled food that can make you sick. They're deeply tied into our quality of life, our nutrition, even how we interact socially. And when they don't work right, the consequences, well, they can be pretty significant, both physically and, psychologically.
You mentioned a striking fact earlier, right from the source.
Yes, and it really underscores how vital they are, even for your overall health. It highlights this longitudinal study, involved over 1,000 non-demented elderly people. And the results were, frankly, quite remarkable.
What did they find?
They found that those individuals with the lowest scores on an objective smell identification test at the start, they had a shocking 45% mortality rate over the next 4 years.
45%. Compared to what?
Compared to just 18% mortality in those who had the highest smell scores.
Wow.
And this wasn't just a correlation. The association held up even after they controlled for other things known to affect mortality, other health factors, demographics, you name it.
So it's not just about detecting gas leaks.
It suggests a really fundamental link between how well you smell and your overall health and potentially your longevity. It's profound.
That statistic really makes you stop and think. It's way beyond flavor or immediate dangers. It might actually be linked to how long and how well we live. And remember, this deep dive is specifically for you. We're pulling out the most important details, the analyses from the source material you've provided, guiding you through it like the experts understand it.
Exactly.
So with that incredible context set, let's unpack this world of chemosensation. Starting with the biology, how do we actually smell things? Where do these odor molecules even go?
Right. So the olfactory system starts its work when these chemicals, these odorants, enter the nose. And there are really two main ways they get to the sensory areas.
Do say it.
First is through the front of the nose, just normal breathing in or actively sniffing.
Right, like smelling flowers.
Exactly. That's called orthonasal olfaction, smelling something before it gets to your mouth. The second way is through the back of the nose. It comes up from the throat, the nasopharynx, when you're swallowing or chewing food.
Ah, so that's the flavor part when we eat.
Precisely. That's retronasal olfaction. And it's absolutely critical for what we perceive as flavor. It's a huge part of the experience.
Okay, so they enter orthonasally or retronasally. Where do they go then?
From there, these odorants travel upwards and backwards, deep into the nasal cavity, reaching the very highest parts. This specialized area is often called the olfactory cleft, and it's lined with a unique kind of tissue.
And they have to dissolve first.
Yes, that's key. Before they can be detected, they need to dissolve in this thin layer of olfactory mucus that covers the area. Once dissolved, they either diffuse through the mucus or they're actively carried by special odorant-binding proteins within that mucus to reach the actual sensory cell.
The receptor cells.
The olfactory receptor cells, exactly. These are the absolute key players. They're neurons, actually. And they're located within this very special tissue called the olfactory neuroepithelium.
Neuroepithelium sounds different from the rest of the nose lining.
It is very different. It's not like the standard respiratory lining. It's a unique pseudostratified columnar epithelium. And it only covers specific areas. The underside of that cribriform plate, that delicate sieve-like bone at the base of the skull. and also parts of the superior nasal septum, the superior turbinates, and sometimes even the middle turbinates.
And what do these cells look like?
Each one is a bipolar neuron. It has a dendrite reaching up to the surface, ending in a little knob. From that knob, multiple tiny non-moving cilia project out into the mucus layer.
That's where the receptors are.
That's exactly where the odor receptors are located, on those cilia. Then from the other end of the cell body, a thin, unmyelinated axon goes downwards, carrying the signal towards the brain. The source even has a figure, 33:1, showing this setup.
You said this neuroepithelium is unique. What's so special about it compared to, say, skin cells or even the regular nasal lining?
Well, it's quite remarkable, especially for nervous tissue. One of its most amazing properties is its ability to regenerate.
Regenerate. Neurons regenerating.
Yes. Unlike most neurons in your brain or spinal cord, these olfactory receptor cells, if they get damaged by, say, an injury or a bad infection, they can be replaced. There are basal stem cells located near the bottom layer of the epithelium that can divide and create new receptor cells.
So if you lose your sense of smell, it can come back.
It can. But, and this is a big but, the source points out, this replacement process is often incomplete, especially after really significant damage. So while that potential for regeneration offers hope for recovery, the fact that it's often not fully complete is a major reason why smell loss can sometimes be permanent.
Okay, so back to those cilia on the receptor cells, that's where the magic happens, the detection.
That's right. Embedded in the membranes of these cilia are the odor receptors themselves. The vast majority, nearly 400 different types in humans, are G protein-coupled receptors, GPCRs.
400 types, it's a lot.
It's a huge number. And here's a really crucial bit of organization. Typically, each individual olfactory receptor cell expresses only one functional type out of those roughly 400 GPCRs.
Only one type per cell.
Yes. This creates this incredible diversity at the cellular level. You have this plethora of receptor cell types, each one tuned to respond best to a specific group of odor molecules. This diversity is way greater than what you see in other senses like vision, with just a few photoreceptor types or hearing.
Are there other receptor types besides GPCRs?
Yes, the source does mention others. While GPCRs are the main players, there are also trace amine-associated receptors, TARs, and members of the MS4A protein family found on subsets of these cells. Adds another layer of complexity to how we detect odors.
Okay, so the receptor cells, each specialized, detect the odorants. They convert that chemical signal into an electrical one. What's the next step in the pathway? How does that signal get processed further in the brain?
Right, so from these olfactory receptor cells, their axons extend downwards away from the mucus. They bundle together into small groups called phyla olfactoria, or just phyla. These bundles are supported by glia-like cells called ensheathing cells. And then these phyla, these bundles of axons, pass upwards through those tiny holes in the cribriform plate bone.
Like threads through a sieve, you said.
Exactly like threads through a sieve. They pass through the bone to reach the olfactory bulbs.
The olfactory bulbs, where are they located?
They're bilateral structures, one on each side, sitting right on the underside of the frontal lobes of the brain. They rest directly on top of the cribriform plate. These bulbs are the first major relay and processing centers for all the olfactory information coming into the brain.
And what happens inside the bulbs?
Inside the bulbs, those incoming axons from the receptor cells make connections, they synapse, with the dendrites of the main projection neurons. These synapses happen within distinct spherical structures called glomeruli. The source has a diagram, figure 33-2, showing the bulb structure and these glomeruli.
Glomeruli. That sounds like some kind of sorting station or filter.
That's a great way to think about it. Glomeruli are definitely a major site of convergence and initial processing. Many more axons from the receptor cells enter a single glomerulus than the number of projection neurons that leave it. So information is funneling down. And here's where the organization gets really elegant. All the olfactory receptor cells scattered throughout the epithelium that express the exact same type of odor receptor GPCR. They all send their axons to converge and synapse within the same two corresponding glomeruli in the olfactory bulb on that side, usually one medially, one laterally.
Wow. So each glomerulus is specialized.
Effectively, yes. Each glomerulus acts like a dedicated processing unit, receiving and integrating information related specifically to the activation of one type of odor receptor. It's a beautiful system for sorting the input.
Are there other cells in the bulb besides the incoming axons and these projection neurons?
Oh yes, several important types. The main output neurons, the ones sending the signal deeper into the brain, are called mitral cells and tufted cells. Their main dendrites reach into the glomeruli to receive those excitatory inputs from the receptor cell axons. They also connect with dendrites of paraglomerular cells.
And what do those do?
Paraglomerular cells, along with another numerous type called granule cells, are primarily inhibitory interneurons. They play crucial roles in modulating, kind of fine-tuning the activity of the mitral and tufted cells, sharpening the signal, you could say. And interestingly, these granule cells also receive inputs back from more central brain structures.
Top-down influence, even this early.
Exactly. It hints that even at this first processing stage in the bulb, the rest of the brain can influence how olfactory information is being handled. It's not just a one-way street.
And you mentioned regeneration earlier. Does the bulb itself have some capacity for that too? Not just the epithelium?
That's another fascinating aspect, yes. While the main output neurons, the mitral and tufted cells, don't typically regenerate in adults, some of those inner neurons we just talked about, specifically the granule cells and paraglomerular cells, are subject to replacement throughout life.
How does that happen?
There's a region in the brain called the anterior subventricular zone, where new neurons, neuroblasts, are continuously generated. These neuroblasts then migrate along a specific path, called the rostral migratory stream, all the way to the olfactory bulb. Once they arrive, they differentiate into functional granule and paraglomerular cells, integrating into the existing circuitry. It adds another layer of a dynamic plasticity to this whole system.
Okay, so signal detected in the epithelium, relayed and processed in the bulb. Where does that refined signal go next? How do we get to the point of consciously identifying, say, coffee versus cinnamon?
Right, so the axons from those mitral and tufted cells in the bulb project further into the brain, forming what's called the olfactory tract. These fibers then synapse within what are called secondary olfactory structures. Collectively, these largely make up the primary olfactory cortex, or POC. The source has figure 33-3 illustrating this pathway beyond the bulb.
Primary olfactory cortex, POC. What parts of the brain does that include?
The POC is defined as those cortical areas that get direct input from the olfactory bulb without any intermediate relay station. In humans, the most notable parts of the POC are the piriform cortex and the entorhinal cortex, both located deep within the temporal lobe.
Now, you mentioned something unique about olfaction compared to other senses, didn't you? Something about the thalamus.
Yes, this is a really key difference. Unlike vision, hearing, or touch, where the sensory information typically goes through the thalamus, that major relay center in the middle of the brain before reaching the cortex. The initial projections from the olfactory bulb to the primary olfactory cortex largely bypass the thalamus.
It goes straight to the cortex.
Pretty much, for that first cortical stop. However, the source makes important clarification. Even though it bypasses the thalamus initially, damage to the thalamus can still cause certain types of olfactory problems. Specifically, problems with odor identification. The thinking is that the thalamus likely plays a crucial role later in the pathway, relaying information between the POC, like the piriform cortex, and other higher-order cortical areas, particularly the orbitofrontal cortex, or OFC.
The OFC, that's where the conscious identification happens.
That seems to be a major site for conscious odor identification, discrimination, and evaluating the pleasantness or unpleasantness of smells.
And then there are those really famous connections, the ones between smell and emotion and memory, that involves areas like the amygdala and hippocampus, right?
Absolutely. Those connections are incredibly direct and powerful. The olfactory pathways have very close anatomical ties to brain structures like the amygdala.
Which is heavily involved in emotion.
Right. And the hippocampus, which is absolutely crucial for forming and retrieving memories. These direct links are really central to why smells can trigger such strong emotional responses and vivid memories.
Like Proust's Madeleine moment.
Exactly like that. It explains why a particular scent can instantly transport you back to childhood, evoking a powerful feeling even before you consciously place the smell. The olfactory system isn't just detecting chemicals, it's deeply woven into our emotional and cognitive fabric, influencing memory, motivation, arousal, even basic functions like digestion and sexual behavior through these connections.
It's an incredibly intricate system. Okay, let's shift gears now to its partner sense. Taste or gustation. We usually think of taste just happening on the tongue, right, on those little bumps. But you mentioned it's more widespread.
It definitely is more widespread than just the tongue, although the tongue is certainly where the action is concentrated. The chemical stimuli for taste, which we call tastants, are sensed by specialized receptor cells located within structures called taste buds.
Taste buds. The source described them as grapefruit-like.
Yeah, grapefruit-like segmented structures, the memorable image. And these taste buds are found, yes, on the tongue, primarily on the sides and the top surface, the dorsum. But they're also found on the roof of the mouth, specifically the soft palate. And even further back in the pharynx, the larynx, and the upper part of the esophagus. Figure 33 to 4 in the source shows these locations.
And on the tongue, they're inside those bumps we see, the papillae.
Precisely. The lingual taste buds, the ones on the tongue, are embedded within these visible structures called papillae. There are three main types that have taste buds. The fungiform papillae, which are mushroom-shaped and scattered over the front two-thirds of the tongue. Then the foliate papillae, which are like folds on the sides of the tongue towards the back. And the circumvallate papillae, which are those large dome-shaped ones arranged in a V-shaped way at the back.
Are there papillae without taste buds?
Yes, the most numerous type, the filiform papillae, which cover most of the tongue's surface and give it its texture, they don't contain taste buds. They're mainly for feeling texture.
Okay, so how does the detection process work within a taste bud?
Well, first, the tasting chemical has to be dissolved in liquid, primarily saliva, in the mouth. Once it's dissolved, it enters a tiny opening on the surface of the taste bud called the taste pore. Inside the bud, the dissolved tastant reaches and binds to specific receptors located on microvilli. These are tiny finger-like extensions of the taste receptor cells housed within the bud.
And that binding triggers a signal.
Exactly. The binding causes a change in the electrical potential across the taste cell's membrane. This change then leads to the release of neurotransmitters from the base of the taste cell. These neurotransmitters then activate the nerve endings of the first-order taste neurons that are connected to that taste bud, sending the signal on towards the brain.
How many taste buds do we typically have?
Humans have quite a few, estimated around 7,500 on average. But the source notes an interesting point. Not all of these structures actually contain taste-sensitive cells. And even within the ones that do, some might have cells mainly sensitive to just one type of taste, like sweet, while others might have cells responding to several different tastes.
And the number of cells per bud varies too.
Greatly. It can range from 0 taste cells in some buds to over 100 in others. There's a lot of variability.
So how do we distinguish the classic basic tastes? Sweet, sour, bitter, salty, and umami. Are there different receptors for each, like with smell?
Yes, absolutely. There are distinct molecular mechanisms and specific receptor families for detecting these different basic taste qualities. Sweet tastes, often signaling carbohydrates, and umami tastes, signaling amino acids like glutamate.
The savory taste.
Exactly, that savory taste. These are mediated by a small family of just 3 G-protein-coupled receptors, GPCRs, T1R1, T1R2, and T1R3. Different combinations of these detect sweet or umami. Bitter sensations, on the other hand, which often signal potentially harmful toxins, rely on a much larger family of receptors called the T2Rs.
How many of those?
There are about 30 different T2R GPCRs in humans. And importantly, the source notes these T2R receptors are generally expressed on different taste cells than the ones that sense sweet and umami.
So bitter has its own dedicated cells.
Largely, yes. And while this large family of T2Rs allows us to detect a huge variety of structurally different bitter compounds, they generally don't allow us to distinguish between different bitters. Activation of pretty much any T2R signals bitter in our general aversive way.
Okay, what about sour and salty?
Sour tastants, which indicate acidity, are primarily sensed by a receptor called PKD2L1. This is actually a member of the TRP channel family.
TRP channels. Aren't those involved in temperature and pain too?
They often are, yes. It shows some overlap in the molecular machinery for different types of chemical sensing. And salty sensations, particularly from simple salts like sodium chloride, table salt, arise mainly from sodium ions, NEAT+, directly entering the taste receptor cells through specialized ion channels in the membrane, like the epithelial sodium channel, or ENaC.
Fascinating. Now, about that really intriguing discovery mentioned in the source taste receptors being found elsewhere in the body, not just the mouth, that seems like a huge shift in understanding.
It really is. It's one of the most exciting developments in chemosensation research in recent years. It basically generalizes the whole concept of chemical sensing way beyond just taste and smell as we traditionally define them. It's now very well established that receptors related to both bitter and sweet tastes are present in many other parts of the body.
Where specifically?
Most notably in the digestive system, the alimentary tract, and also in the respiratory tract.
So our gut and lungs have taste receptors?
In a manner of speaking, yes. These tissues are equipped with molecular sensors, very similar to those on our tongue. They act like chemical sentinels, monitoring the internal environment.
Can you give an example?
Sure. Alpha-gustation, that's the specific G protein subunit crucial for signaling in taste buds, is also found in specialized cells called brush cells. And these brush cells are located in places like the human trachea, the lungs, the pancreas, even the gallbladder.
What do these brush cells do?
They're interesting. They're rich in nitric oxide synthase, the enzyme that makes nitric oxide, or NO. And NO does a lot of things. It helps defend against microbes, protects the lining from acid, and in the gut, it stimulates the vagus nerve and other nerves that signal to the brain about what's happening down there. NO can also act locally on other nearby cells, hormone-releasing cells, epithelial cells, blood vessels, immune cells.
So gut feelings might involve actual gut tasting.
That's not too far off. And members of the T2R bitter receptor family and the T1R sweet receptor family have also been found directly in the GI tract. And in enteroendocrine cells, those are the gut cells that release hormones controlling digestion and metabolism.
How are they involved in metabolism?
They play important roles. For instance, T1R3 receptors and gustation in the gut are critical for sensing dietary sugars right there in the intestinal lumen. This sensing triggers pathways for absorbing those sugars, partly via the SGLT transporter, and it also regulates the release of key gut hormones like GLP-1 and CCK.
Which affect insulin and feeling full.
Exactly. They influence insulin secretion and satiety signals. So gut taste directly impacts your metabolism.
What about in the airway? You mentioned receptors there too.
Yes, in the airway, T2R bitter receptors are found on the motile cilia, those little hair-like structures that line the respiratory tract. When these receptors get stimulated by bitter compounds, maybe from bacteria or pollutants, it actually triggers an increase in the beat frequency of the cilia.
Making them beat faster.
Yeah. It's thought to be a protective reflex, helping to clear potential irritants or pathogens out of the airway more quickly, like sweeping the floor faster when something nasty lands on it.
That makes sense.
And there's an even more specific example. A particular bitter receptor, T2R38, is highly expressed in the upper respiratory lining. This receptor specifically responds to certain molecules that bacteria use to communicate, quorum-sensing molecules, particularly from bugs like Pseudomonas aeruginosa, a common respiratory pathogen.
Okay.
Now here's where it gets really clinically relevant for you. People have different versions, different genotypes of the gene for this T2R38 receptor, T2R38. Some versions result in a receptor that doesn't function as well. And studies have actually shown that individuals with these less functional TS2R38 genotypes have a higher susceptibility to getting upper respiratory infections.
Wow. So my genes for a taste receptor in my nose could affect how likely I am to get a cold or sinus infection.
That's exactly what the research suggests. It directly links a specific taste receptor outside the mouth and your personal genetic makeup for it to your individual risk for certain common illnesses. It completely reframes these receptors.
It really does. They're not just for food enjoyment. They're integrated chemical sensors affecting metabolism, immunity, disease risk.
Right.
Mind-blowing. Okay, back to the classic taste pathway. Once the signal is generated in the taste bud in the mouth, how does that information get transmitted to the brain?
Taste information gets to the brainstem via 3 different cranial nerves. Figure 33-5 in the source shows these pathways.
3 nerves for taste. Okay.
First is cranial nerve 7th, the facial nerve. Its taste fibers travel in specific branches, mainly the chorda tympani nerve and the greater petrosal nerve. This nerve bundle carries taste from the front, 2/3 of the tongue, and also from the soft palate.
The chorda tympani, that name sounds familiar. Doesn't it run through the ear?
It does. It has a really interesting and clinically important path. It actually loops up and passes right through the middle ear space, which is why ear infections or ear surgery can sometimes affect taste. After passing through the ear, it joins up with the lingual nerve, which carries general sensation from the tongue.
And CNC does other things too, right? Saliva.
Yes, branches of CNZ also carry parasympathetic fibers that control the submandibular and sublingual salivary glands and the palatine glands. Saliva flow is crucial for dissolving taste, so that's an important connection.
Okay, so CNZM for the front of the tongue and palate. What are the others?
Second is cranial nerve 9X, the glossopharyngeal nerve. This one carries taste information from the back 1/3 of the tongue, including those big circumvallate papillae. Third is cranial nerve X, the vagus nerve. This carries taste signals from even further back from receptors on the epiglottis, in the larynx, and even the very top part of the esophagus.
So taste input comes from quite a wide area.
It really does. And we also have to remember cranial nerve V, the trigeminal nerve, specifically its mandibular branch, V3.
That's not taste though, right? That's sensation.
Correct. It doesn't carry the basic taste qualities, but it carries all the crucial somatosensory information from the mouth. Touch, pressure, temperature, hot and cold, and chemical irritation like the burn from chili peppers or the cooling sensation from menthol. This trigeminal information travels along shared pathways with the taste nerves, and it's the combination of true taste, sweet, sour, etc., this somatosensory input, texture, temperature, burn, and critically, that retronasal smell coming up from the back.
That creates the full experience of flavor.
Exactly. Flavor is inherently multimodal. You need all those pieces working together.
It's like an orchestra, truly.
Yeah.
Okay, so where do the signals from these three taste nerves, 7i, X, and X, first land when they enter the brainstem?
They all converge and make their first synapse in the rostral or upper, part of a structure called the nucleus of the solitary tract, the NTS. This is located in the medulla, down in the brainstem. It's the first central relay station for taste.
And from the NTS in the brainstem, where next? Does it go through the thalamus like other senses?
Yes. Unlike olfaction's initial bypass, taste information does relay through the thalamus. Neurons from the NTS project upwards, traveling via a pathway called the medial lemniscus to reach a specific part of the thalamus known as the ventropostromedial nucleus, or VPM.
VPM in the thalamus, and then to the cortex.
Then from the VPM, taste projections travel to the brain region, considered the primary taste cortex, or PTC. This is located in the rostral part of the frontal operculum, and the adjoining insula area is kind of tucked away deep inside the lateral sulcus, the fold separating the temporal lobe from the frontal and parietal lobes.
That's where initial conscious perception of taste happens.
That seems to be where the initial cortical processing of taste quality as its sweet, salty, and intensity occurs.
Is there a secondary taste area, too?
Yes. From the primary taste cortex, there are further projections to what's called the secondary taste cortex. This area is located in the caudolateral part of the orbitofrontal cortex, the OFC.
Ah, the OFC again. We saw that with smell identification.
Exactly. And in the context of taste and flavor, this OFC region is particularly interesting because it contains neurons that respond to inputs from multiple senses: taste, smell, or especially retronasal, and somatosensation from the trigeminal nerve. Because it integrates all these different signals, the OSC is thought to be a key hub for creating that final, unified perception of flavor.
So that's the incredible, complex, and really interconnected biology underlying smell and taste and flavor. But we know these systems can be quite fragile. Things go wrong. What are some of the common disruptions, the disorders that affect our sense of smell, olfaction?
Well, our ability to smell is remarkably sensitive. It's influenced by a whole host of factors in everyday life, and also by many disease states. Age is a really big one. There's a natural progressive decline in smell function as we get older. This is called presbyosmia.
Presbyosmia, like presbyopia for vision.
Exactly the same idea. Gender also plays a role. Studies consistently find that women, on average, tend to perform better on smell tests than men, and they often maintain better function later in life. The source's figure 33-6 actually shows this age-related decline and the gender difference using scores from that UPSIT smell test.
What else influences it day to day?
Things like your general health, your nutritional status, definitely smoking habits, that's a major negative factor, and even your reproductive state can all influence how well you smell.
And this age-related decline, presbyosmia, it has real-world consequences, doesn't it?
It really does. The source highlights this. It's a major reason why many older adults report that food just doesn't taste as good. It lacks flavor.
Which can affect appetite and nutrition.
Absolutely, leading to decreased appetite, maybe poor nutrition. And tragically, it also helps explain why a disproportionate number of elderly individuals die in accidental gas poisonings. They simply can't detect the warning smell effectively anymore.
That's sobering. Beyond just normal aging, what are the big identifiable causes of smell loss that doctors see most often in the clinic? The things that cause long-lasting or even permanent problems?
Based on clinical data from specialized centers, the three most common identifiable causes for significant persistent smell loss are, in order of frequency: 1, severe upper respiratory infections, or URIs; 2, head trauma; and 3, chronic rhinosinusitis.
Okay, let's break those down. Head trauma, how does that cause smell loss? Is it about fracturing the skull?
Not necessarily. The main mechanism is often the shearing, the tearing of those delicate olfactory fella, the axon bundles, as they pass up through the tiny holes in the cribriform plate. The source emphasizes that the bone itself doesn't even need to be fractured on an X-ray or a CT scan for this shearing injury to the nerves to happen. Just the forces involved in the trauma can be enough.
And the severity matters.
Yes. The severity of the head trauma, things like a poor initial Glasgow Coma Scale score or a longer period of post-traumatic amnesia, is strongly linked to a higher risk of developing significant smell loss. And unfortunately, recovery from this kind of post-traumatic anosmia, or total loss of smell, is quite limited. The source states less than 10% of these patients regain what would be considered normal smell function for their age.
Less than 10%. That's low. Okay, what about upper respiratory infections, URIs? How do they damage smell?
With URIs, the damage is often more direct, targeting the olfactory neuroepithelium itself. Viruses like the common cold, influenza, pneumonia, and more recently HIV and especially COVID-19 can directly injure this specialized sensory tissue, and sometimes permanently.
Ow.
They can kill off olfactory receptor cells, reducing the total number. They can damage the cilia on the surviving cells where the receptors are. And in some cases, the damaged sensory epithelium can get replaced by the less sensitive standard respiratory epithelium, which can't detect odors.
Smell loss with COVID became really well known.
Extremely well known. It was often one of the earliest symptoms. And intriguingly, in many COVID cases, the smell loss seemed to happen even without a lot of nasal congestion or inflammation, suggesting the virus might have a direct neurotropic effect, attacking the olfactory system itself.
And the third common cause was chronic rhinosinusitis.
Right. Chronic inflammation of the nose and sinuses. Here, the smell loss is generally related to how severe the inflammation and obstruction are. It tends to be worst when the rhinosinusitis is accompanied by significant nasal polyps, those growths that can physically block airflow to the olfactory cleft way up high in the nose.
Can treatment for the sinusitis help the smell?
Often it can, yes. Medical treatments, especially systemic steroids, can reduce the inflammation and swelling, leading to short-term improvement in smell. Surgical treatment to remove polyps and open the sinuses can also help. However, the source notes that even with treatment, smell scores often don't return completely to normal. Why? It implies that there might be some underlying permanent neural damage from the chronic inflammation, or perhaps the inflammation isn't being completely controlled even with treatment. The source also makes the point that even subtle microscopic inflammation in nasal tissue that looks normal during an exam can still cause significant smell impairment. The system is very sensitive.
So those are the big three: URIs, head trauma, chronic rhinosinusitis. But it sounds like smell can also be affected by, or even be an early sign of, a whole range of other systemic diseases.
Oh, absolutely. Smell dysfunction is linked to a remarkably wide spectrum of other medical conditions. It often reflects either the systemic impact of the disease or specific effects on nerve tissue. The source provides a really helpful table, Table 33-1, listing many of these connections.
Can you give some highlights?
Sure. Big categories include endocrine and metabolic conditions. Things like diabetes, hypothyroidism, chronic kidney disease, liver disease, Cushing's syndrome, Addison's disease, and notably Kallmann syndrome, that genetic condition linking absent puberty and anosmia. Immune-related diseases. This includes common things like allergic rhinitis and asthma, but also various autoimmune diseases, lupus, multiple sclerosis, MS, Sjogren's syndrome, rheumatoid arthritis, giant cell arteritis. These likely involve inflammation affecting the olfactory pathways.
Makes sense.
Other nasosinus disorders besides chronic rhinosinusitis, like enlarged adenoids blocking the back of the nose, or laryngopharyngeal reflux disease, where stomach acid irritates the upper airway. And then a really critical category, neurologic diseases.
This seems like a major focus in the source.
It is. The source strongly emphasizes that decreased smell function, often problems with sensitivity and identifying odors, is frequently one of the very first detectable signs in several major neurodegenerative diseases. It can appear years before the more classic motor or cognitive symptoms become obvious.
Which diseases specifically?
Particularly Parkinson's disease, PD, and Alzheimer's disease, AD, but also others like Huntington's disease, dementia with Lewy bodies, DLB, multiple system atrophy, corticobasal degeneration, frontotemporal dementia, even Down syndrome. And as mentioned, multiple sclerosis can cause smell loss too, due to inflammatory lesions in olfactory brain areas.
Can you elaborate on the Parkinson's and Alzheimer's link? That seems really significant for early detection.
It's a huge area of research. In Parkinson's, smell loss very often predates the clinical diagnosis of motor symptoms like tremor or stiffness, sometimes by many years. It's one of the earliest non-motor symptoms. In fact, studies looking at how the abnormal protein aggregates, the alpha-synuclein that forms Lewy bodies, spread through the brain in PD, suggest that the olfactory bulbs, right there at the front receiving smell input, might be one of the very first places this pathology starts, along with the nucleus in the brainstem connected to the vagus nerve.
Wow, starting in the smell system. What about Alzheimer's?
Similarly, in people considered pre-symptomatic for Alzheimer's, maybe they have risk factors or biomarkers, but no dementia. Yet studies have found that poorer smell function measured while they were alive correlates strongly with higher levels of Alzheimer's pathology, like amyloid plaques and tau tangles found in their brains after death.
So smell testing could be a biomarker.
It's definitely being investigated heavily as a potential early non-invasive biomarker. Smell loss also seems to be more pronounced in early dementia with Lewy bodies compared to early Alzheimer's, so it might help differentiate those conditions sometimes.
Are there any movement disorders where smell is not affected?
Interestingly, yes. The source notes that significant smell loss is typically minimal or absent in conditions like progressive supranuclear palsy, PSP, and also in Parkinsonism caused by the toxin MPTP. This difference raises really interesting questions about why smell is affected in PD and AD. Is it specific to the alpha-synuclein or amyloid pathologies? Or is it related to damage to certain brain chemical systems, like dopamine or acetylcholine, that might be affected differently in these various diseases? It's still being worked out.
Fascinating. The source also mentioned a link between smell loss and REM sleep disorders. That seems less obvious.
It does, but it highlights these intricate brain connections. The degree of smell loss seen in people with idiopathic REM behavioral sleep disorder, or IRBD.
Where people act out their dreams.
Exactly. The smell loss in IRBD is noted as being very similar in severity to that found in people already diagnosed with Parkinson's disease.
And why is that significant?
It's highly significant because people with IRBD have a greatly increased risk of eventually developing Parkinson's disease or another related condition like DLB. And hyposmia, reduced smell, is a very common feature when they do convote.
Okay, that connects it back to PD. What about narcolepsy?
RM behavior disorder can also occur in narcolepsy. But a study cited in the source found that narcolepsy itself, even without the sleep behavior disorder, was linked to olfactory impairment.
Any idea why?
The proposed mechanism involves the loss of specific neurons in the hypothalamus that produce neuropeptides called orexins or hypocretins. These neurons are known to be deficient in narcolepsy. And these orexin neurons project widely throughout the brain, including extensively to the entire olfactory system, from the bulbs right up to the cortex.
So loss of orexin could directly impact smell.
That's the hypothesis. Damage to these orexin projections might underlie the smell problems in narcolepsy. And supporting this idea, one small study actually found that giving intranasal orexin A improved olfactory function in narcoleptic patients.
Suggesting orexin deficiency is directly involved.
Exactly. It suggests mild smell impairment might be a core feature of narcolepsy, directly linked to the orexin loss.
Incredible connections. The source table also listed many other causes, right? Just briefly.
Yes, a very diverse list. Various other infections, viral, bacterial, fungal, beyond just colds, like candidiasis, hepatitis C, HIV, leprosy, exposure to certain chemicals, congenital problems from birth, iatrogenesis, meaning problems caused by medical treatments, especially chemotherapy and head and neck radiation, specific nutritional deficiencies like vitamin B12, obesity, tobacco smoking, of course, and exposure to various environmental or occupational toxins. It really highlights how vulnerable the system is.
It's an incredibly extensive list for smell problems. Okay, let's turn to taste disorders now. The source started with that surprising claim. Most patients complaining about a loss of taste actually have a problem with their sense of smell. Why is that the common scenario?
It comes right back to that concept of flavor we discussed. What most people call taste in everyday language, the rich, complex sensation of food, is largely driven by retronasal olfaction.
The smell signals coming up from the mouth during chewing.
Exactly. Those odorants reaching the olfactory receptors from the back. True taste, sensed by the taste buds, is really just those 5 basic qualities. Sweet, sour, bitter, salty, umami. So when someone says food lacks flavor or tastes bland, it's far more likely that the olfactory component is missing or reduced, rather than a complete loss of basic tastes.
Is it rare to have a significant loss of just the basic tastes?
The source suggests that significant impairment of whole mouth taste function is relatively uncommon compared to smell loss.
Unless
Unless there are widespread metabolic problems going on, or the person is taking certain systemic medications.
Why is it rare?
2 main reasons. First, taste buds have that capacity to regenerate throughout life, although maybe not perfectly. Second, taste information travels through 3 different cranial nerves, 7, 9, and X, innervating different parts of the mouth and throat. So for a complete widespread loss of taste from peripheral nerve damage alone, you'd need multiple nerve pathways to be severely affected at the same time, which is less likely than damage to the more localized olfactory system unless it's a very systemic issue.
Okay. What factors influence taste function, similar to smell?
Many of the same factors overlap. Age definitely plays a role, though maybe less dramatically than with smell. Diet, smoking, medication use a huge one for taste and other general health factors.
What are some specific ways taste can go wrong, according to the source?
Several mechanisms are described. One is simply the release of foul-tasting stuff right there in the mouth. Think about infections like gingivitis or infected salivary glands, purulent sialadenitis, or even poorly cleaned dentures trapping food particles.
Okay, local contamination.
Right. Another is problems with transport, getting the tastins to the taste buds. This can happen if the mouth is excessively dry, xerostomia, or if there are infections or inflammation affecting the lining of the mouth and tongue.
If the surface is damaged or dry, the tastins can't dissolve and reach the pores.
Exactly. Then there's direct damage to the taste buds themselves. This could be from local trauma, like burning your tongue on hot food, or from invasive cancers in the mouth or throat area destroying the buds. Damage can also occur to the nerve pathways innervating the taste buds. We mentioned the chordotympany nerve, part of CNCN, being vulnerable during middle ear infections or surgery.
Right.
Damage to central brain structures can also cause taste problems, things like MS lesions, tumors, certain types of epilepsy or stroke, although again, smell loss is often more common with these central conditions. And finally, those systemic disturbances are really key causes: uncontrolled diabetes, thyroid disease, and especially systemic medications.
You mentioned cranial nerve damage affecting taste, particularly CNSF through the ear. How common is that?
Damage to the specific taste nerves is definitely a known cause. CN7's chordotympany is probably the most commonly affected due to its path through the middle ear. Ear surgery, mastoidectomy, campanoplasty, stapedectomy can sometimes injure it, leading to persistent metallic tastes or other distortions, called dysgeusia. Bell's palsy, that sudden facial nerve paralysis, is another common cause affecting CN7 and potentially taste.
What about the other taste nerves, IX and X?
CNIX, glossopharyngeal, carrying taste in the back of the tongue, is relatively protected anatomically. But the source notes it can be injured during medical procedures, iatrogenic causes like tonsillectomy, or airway procedures like bronchoscopy, laryngoscopy, or intubation. Head and neck radiation therapy is another big iatrogenic cause that can damage CNIX, X, and 7 taste fibers.
Okay. The source also mentioned a link between taste changes and migraines.
Yes, an interesting connection. Taste alterations, especially dysgeusia, can sometimes occur as part of the migraine prodrome, those warning symptoms before the headache, or as part of the migraine aura itself. And for some individuals, specific tastes or flavors can even act as triggers that bring on a migraine attack.
What about burning mouth syndrome? Taste is involved there too.
Yes, dysgeusia is very common in burning mouth syndrome, also called glossodynia. Patients often also have dry mouth and thirst, along with that burning or scalding sensation, usually without any obvious sores. It's thought to be linked to dysfunction of the trigeminal nerve, CNV, which handles sensation in the mouth.
Are there treatable causes for burning mouth?
The source lists several potential underlying causes that can be treated, which is important. These include nutritional deficiencies, specifically iron, folate, B vitamins, especially B12, and zinc. Also diabetes, which might lead to oral yeast infections, candidiasis that cause burning, allergies or irritation from dentures, repetitive mouth habits, rarely tongue ischemia, poor blood flow, maybe from temporal arteritis, periodontal disease, acid reflux, geographic tongue. Finding and treating one of these underlying issues is often the key.
Medications seem to be highlighted as a really major factor for taste problems, maybe even more than for smell.
That's what the source suggests, yes. Taste alterations are reported to be more common side effects than smell alterations, and the number is quite staggering. Over 250 different medications have reportedly been linked to altered taste perception.
Wow. What kinds of drugs are major culprits?
They span many classes. Antineoplastic agents used in chemotherapy are notorious offenders. Antirheumatic drugs, many antibiotics, lots of blood pressure medications, and cardiovascular drugs.
Any specific examples that stand out?
The source gives a couple of notable ones. Terbinafine, that oral antifungal drug.
Used for nail fungus.
Right. It's been linked to significant taste disturbances that can, unfortunately, last a remarkably long time. After stopping the drug, sometimes up to 3 years.
3 years? That's awful.
It is. Another example is isopoqualone, the sleep aid Lunesta. In a clinical trial, almost 2/3 of people taking it reported a bitter dysgeusia, that persistent bitter taste. It was stronger in women, related to how long ago they took the dose, and actually correlated with the drug levels in their blood and saliva. Suggests the drug itself or its metabolites are directly interacting somehow.
The source also mentioned that issue with intranasal zinc cold remedies again, didn't it?
It did, bringing up that potential conflict. These products have been linked to smell loss, likely due to direct toxicity. But URIs, which they're supposed to treat, are the most common cause of smell loss. So the source poses that critical question. Does the potential, often debated benefit of these zinc products outweigh the potential risk of causing possibly permanent harm to your sense of smell? It's a risk-benefit calculation individuals and doctors need to consider.
Right, and chemotherapy and taste.
Yeah.
Very common.
Extremely common. Dysgeusia is frequent and bothersome side effect of many chemo drugs. The source quotes prevalence rates between 56% and 76%. Unfortunately, attempts to prevent this using things like zinc sulfate or amifostine before chemo haven't shown much consistent benefit.
What about anti-epileptic drugs?
It's a bit ironic. Some anti-epileptics are occasionally tried to treat chemosensory distortions like phantasmias, but one commonly used anti-epileptic, tapiramet, can itself cause a reversible loss of taste and smell detection and recognition during treatment. It goes away when the drug is stopped.
And systemic disorders affecting taste. You mentioned them briefly.
Yes, reiterated from the smell section. Chronic kidney failure, end-stage liver disease, various vitamin and mineral deficiencies, diabetes, hypothyroidism. With diabetes, the loss seems progressive, starting with reduced sensitivity to sweet things, then salty, eventually affecting all tastes.
Any link to psychiatric conditions?
Yes, conditions like depression, schizophrenia, and eating disorders like bulimia can sometimes be associated with alterations in taste or smell, including hallucinations. However, a review cited in the source found that no specific type of chemosensory hallucination, smell, taste, or even tactile in the mouth, is uniquely diagnostic for any single psychiatric disorder.
Okay. And lastly, pregnancy. That was mentioned as a unique state affecting taste.
Right. Pregnancy brings unique physiological changes that influence taste. The source highlights an interesting pattern. In the first trimester, there seems to be an increased dislike for and heightened intensity of bitter tastes.
Why would that be?
The hypothesis is that it might be an adaptive mechanism. It could help pregnant women avoid accidentally consuming potentially toxic or poisonous substances during that really critical early stage of fetal development when organs are forming, a natural aversion to potential harm.
Makes evolutionary sense. What about later in pregnancy?
Conversely, in the second and third trimesters, there seems to be a relative increase in preference for salty and bitter tastes. The thinking here is that this might help encourage intake of needed electrolytes to support the expansion of the mother's blood volume and also encourage eating a wider variety of foods, which is good for getting diverse nutrients later in pregnancy. Fascinating potential adaptive shifts.
Absolutely fascinating. Okay, so that covers a huge range of ways things can go wrong with both smell and taste. Given this enormous list of possibilities, local problems, trauma, infections, systemic diseases, neuroconditions, meds, even pregnancy, if someone presents to a doctor with a smell or taste problem, how on earth does the clinician start to figure out the specific cause?
It seems daunting, but the source is very clear. In the vast majority of cases, the single most crucial step is taking a really careful, thorough, detailed clinical history from the patient.
The history is key. What kind of questions are essential?
You need to pin down the specifics. The exact nature of the problem. Is it complete loss? Anosmia, reduced sensitivity, hypogesia, a distorted perception, dysosmia, or a phantom sensation, a hallucination, phantasmia, phantagesia. Then, the onset. When did it start? Was it sudden or gradual? The duration. How long has it been going on, and any fluctuations? Does it come and go, or is it constant?
How does the onset help narrow it down?
Well, a very sudden onset might point towards things like head trauma, a stroke affecting sensory pathways, ischemia, an acute infection, or maybe a psychiatric condition presenting with sudden hallucinations. A gradual loss might suggest something slowly developing, like a tumor obstructing the nasal passages, or the progressive decline seen in neurodegenerative diseases. Though gradual loss can also happen after head trauma sometimes. And if it's intermittent, coming and going. That strongly suggests an inflammatory process is at play, like allergies flaring up or chronic sinusitis that waxes and wanes.
What about precipitating events, things that happened right before it started?
Absolutely critical to ask about. Patients might not connect a recent cold or flu to their smell loss weeks later, so you have to ask specifically about recent URIs that are so common as triggers. Also, a detailed history of any head trauma, even seemingly minor bumps. Smoking history is vital. Any history of drug or alcohol abuse. The source specifically calls out intranasal cocaine use, which damages nasal tissue, and chronic heavy alcohol use, which could lead to nutritional issues and liver problems affecting these senses.
And medications, you stressed that earlier.
Cannot stress it enough. The clinician must get a meticulous list of every single medication prescription over the counter, supplements that the patient was taking immediately before and when the symptoms started. Remembering that list of over 250 drugs is key.
What about other existing medical conditions?
Essential to ask about comorbid conditions known to affect smell or taste. Kidney failure, liver disease, hypothyroidism, diabetes, any known dementia or other neurological diagnoses. Sometimes a specific cluster of symptoms points to a syndrome, like that example of delayed puberty plus anosmia, suggesting Kalman's syndrome, especially if there are other related physical findings.
Do other associated symptoms help localize the problem?
Yes, definitely. Asking about things like nosebleeds, epistaxis, the type of nasal discharge, is it clear watery like allergies, thick colored like infection or bloody? Any feeling of nasal blockage, history of allergies, or other symptoms like headache or irritation in the nose or mouth can provide valuable clues.
And screening for neurological issues seems vital, given those links.
Mandatory. Questions about memory problems, any symptoms suggesting Parkinsonism, tremor, stiffness, slowness, any history of seizures or seizure-like events, auras, blackouts, deja vu experiences, as some temporal lobe seizures can manifest with olfactory or gustatory phenomena.
The source also mentioned considering malingering.
Yes, from a practical standpoint, especially if there's ongoing litigation related to an injury or exposure, the possibility of malingering or faking exaggerating symptoms needs to be kept in mind. Interestingly, the source notes that modern quantitative smell tests, particularly forced choice ones, are actually quite good at detecting statistically improbable patterns of answers that strongly suggest someone isn't responding genuinely.
So the history is the absolute foundation. What comes next? Physical exams, imaging, blood work.
Yes. After the history narrows things down, a thorough neurologic exam and an laryngologic ORL, ear, nose, and throat exam are crucial. Imaging and blood tests might follow based on the findings.
What's the focus of the neurologic exam?
The focus is on assessing the function of all the cranial nerves, looking for any deficits that might point towards lesions at the base of the skull or within the brain itself that could be compressing or damaging the olfactory or gustatory pathways. A careful visual exam is also part of this, checking visual acuity, peripheral visual fields, and examining the optic nerves at the back of the eye with an ophthalmoscope.
Why the eye exam?
Because increased pressure inside the skull, maybe from a tumor growing near the olfactory structures, can cause swelling of the optic nerve head, papilledema, or eventually damage the optic nerve, optic atrophy. The source mentions Foster-Kennedy syndrome as a classic example, where you have signs of raised pressure in one eye and optic atrophy in the other, often caused by tumors like olfactory groove meningiomas right near the smell pathways.
Okay. And the ORL exam, what are they looking for there?
The ENT specialist does a thorough assessment of the inside of the nose, looking at the structure and the mucosal surfaces, usually with a speculum and often a thin camera called an endoscope. They're looking for any physical blockages, a badly deviated septum, nasal polyps, tumors, adhesions, or scarring between structures, anything that could physically stop air-carrying odorants from reaching that olfactory cleft way up high.
That critical smelling area.
Right. And remember, the source said normally less than 20% of inhaled air even reaches that cleft during quiet breathing, so even small blockages can have a big impact. The ENT also assesses the health of the nasal lining, looking for signs of inflammation, infection, dryness, etc. And a thorough check of the oral cavity and pharynx is done to look for local causes of taste problems.
When would blood tests be helpful?
Blood tests can help identify or rule out underlying systemic issues suspected from the history or exam. Things like checking blood sugar for diabetes, inflammatory markers for infection or autoimmune disease, screening for heavy metal exposure if relevant, checking levels of certain vitamins like B12 or minerals like zinc if deficiency is suspected, allergy testing, and assessing thyroid, liver, and kidney function.
Now, the source really emphasized the importance of quantitative testing, actually measuring smell and taste function objectively. Why is that considered so critical?
It's critical for several reasons. Firstly, as we mentioned, patient self-reports can be unreliable. Someone might complain bitterly of loss, but test within the normal range for their age. Or conversely, someone might not realize how bad their loss is until it's measured. So objective testing provides accurate numerical data on the type and severity of the dysfunction. This is essential for a precise diagnosis, for tracking changes over time, and for documenting the impairment objectively, which can be necessary for legal or insurance purposes. And crucially, it's needed to properly assess whether any treatments are actually working or the score is improving.
What's the main test used for smell?
The most widely used and best validated one is the University of Pennsylvania Smell Identification Test, the UPSIT. It's a 40-item scratch and sniff test with multiple choice answers. It has very extensive normative data based on testing almost 4,000 healthy people across different ages and genders.
What kind of results does it give?
It allows you to determine the absolute level of function, classifying the loss as mild, moderate, severe, or total anosmia. It can even identify patterns suggestive of malingering. And importantly, it also gives a relative score, a percentile rank, comparing the person's performance to others of the same age and sex. This helps account for that normal age-related decline.
And you mentioned earlier this testing can actually be therapeutic. How so?
This is a really major point the source makes, and it's often overlooked. Imagine a patient who's been suffering, maybe feeling dismissed by family or doctors who think it's in their head. Getting objective confirmation from a validated test, yes, you do have a measurable loss, can be incredibly validating. It confirms the problem is real and physical, which can reduce anxiety and frustration immensely.
That makes sense.
For patients who test with only a mild loss, the objective data allows the clinician to offer a more positive prognosis, giving them hope. And for older patients, learning that their score, while lower than when they were young, is actually normal or even above average for their current age group, that puts the problem in perspective. It helps them understand it as part of aging, not necessarily a sign of some terrible underlying disease. It counters that feeling of nothing can be done and the depression that can come with it. It's empowering.
Are there other types of smell tests, electrical ones?
Electrophysiological tests exist, like measuring odor event-related potentials from the brain's electrical activity. But the source notes they require complex equipment and usually don't add much useful diagnostic information beyond the history, exam, and standardized behavioral tests like the UPSIT for most clinical situations.
And what about testing taste objectively?
Tests for taste are becoming more common and accessible. Many now use filter paper strips impregnated with different concentrations of the basic tastants: sweet, sour, bitter, salty, umami. They're convenient as they don't require mixing solutions. Electrogustometers, which apply tiny electrical currents to the tongue to elicit taste sensations, are also available in some specialized clinics.
Okay, so after the history, exam, and maybe quantitative testing have hopefully pointed towards a cause or at least characterized the deficit, what are the options for treatment and management? It sounded like the approach has to be very individualized.
Absolutely. The cornerstone of management is, whenever possible, to identify and treat the underlying cause of the chemosensory disorder. That's the most effective strategy.
Can you give examples based on cause?
Sure. The source details several approaches. If the problem is due to an underlying systemic disease like uncontrolled hypothyroidism or diabetes or a systemic infection, then effectively treating that condition often leads to significant improvement in smell and taste.
Makes sense. What if it's a blockage in the nose?
If it's an obstructive or transport issue like severe allergic rhinitis, nasal polyps, tumors, or structural blockages like a deviated septum, then medical treatments like steroids to reduce inflammation or surgical interventions like endoscopic sinus surgery to remove polyps and open passages are often very beneficial for smell. The source mentioned a study finding surgery was particularly helpful for those with severe smell loss beforehand.
What about taste problems caused by mouth infections?
If the taste issue is due to something like oral thrush, candidiasis, or another bacterial infection in the mouth, then appropriate antifungal or antibiotic treatment targeted at that specific infection can often completely reverse the taste problem.
Are there ways to just relieve taste symptoms like distortions?
Sometimes symptomatic relief is needed. Chlorhexidine mouthwash is mentioned as possibly helping with some salty or bitter dysfunctions. For dry mouth, xerostomia, which is a common medication side effect and really impairs taste, using artificial saliva products or medications like pilocarpine to stimulate saliva flow can be helpful.
And medications, if a drug is the suspected cause.
Then the ideal step is to review the patient's full medication list. If a specific drug is highly suspected, and if it's clinically safe and feasible, discontinuing that drug or switching to an alternative with a lower risk of chemosensory side effects is recommended. But there's that important caveat from the source. Many drug-induced taste or smell changes can be very long-lasting. Simply stopping the drug for a short time might not reverse the effect. Recovery, if it happens, can take months or even years in some cases. Patience is needed.
What about using steroids for inflammation?
Yes, for inflammatory conditions in the nose and sinuses, whether from allergies, viruses, or trauma, using intranasal or systemic glucocorticoids, steroids, can help reduce the inflammation and swelling. A tapering course of oral prednisone is a common approach mentioned. Topical intranasal steroids were noted as generally less effective than systemic ones for widespread olfactory inflammation, but the way you administer them might matter using that head down. Moffitt's position could improve delivery to the olfactory cleft.
What about after head trauma? Are steroids used then?
An initial trial of systemic steroids might be considered after a head injury. The rationale is that it could potentially reduce swelling and it maybe minimize scar tissue forming around those delicate olfactory phyla at the cribriform plate. But the evidence for this isn't definitive.
It sounds like treatments are often limited, especially if the nerves themselves are badly damaged.
That's true. We need to be realistic. For primary injury, directly to the neural pathways where the receptor cells, axons, or central structures are severely damaged or lost, our current treatments are unfortunately quite limited. Regeneration is often incomplete.
But you mentioned spontaneous recovery is possible.
Yes, and that's an important note of hope. Improvement can happen over time, even without specific treatment. That follow-up study of over 500 patients found that about half showed at least some modest improvement over 4 years. And it's a significant, but only a minority regained function considered normal for their age. Only 11% of those initially anosmic, total loss, and 23% of those initially hypososmic, partial loss, reached that normal level.
So improvement is possible, but full recovery is less common. What predicted improvement?
Interestingly, in that study, the best predictors of who would improve were the severity of the dysfunction when they first presented. Milder loss had better prognosis, their age, younger, tended to do better, and how long the problem had been going on before they were tested. The specific underlying cause wasn't actually the strongest predictor of prognosis in that particular study, which is a bit surprising.
Okay. Are there any therapies aimed more directly at the senses themselves, trying to stimulate recovery, even if the original cause can't be fixed?
Yes, there's growing interest in olfactory training or smell training. Several studies suggest that patients with smell loss, hyposmia, may benefit from deliberately and repeatedly smelling a set of specific odors over weeks or months.
How does that work? What do they smell?
A typical routine involves smelling 4 distinct odors, often representing different categories like floral, for example, rose or phenyl ethyl alcohol; fruity, for example, lemon or citronella; spicy, for example, cloves or eugenol; and resinous, for example, eucalyptus. They'd sniff each one intently for maybe 30 seconds, usually twice a day, like morning and night.
What's the theory behind it?
The rationale comes partly from animal studies showing that prolonged odor exposure can increase neural activity and maybe even promote some positive structural changes in the olfactory bulb and pathways. Perhaps it stimulates surviving cells or encourages limited regeneration. However, the source adds a note of caution. It's still hard to know exactly how much of the improvement seen with olfactory training is truly due to the training itself versus just the spontaneous recovery that might have happened anyway. Quantifying its specific benefit is tricky.
What about supplements and vitamins? Are they helpful?
The source discusses several, but often with caveats or limited evidence. Alpha-lipoic acid. Some preliminary evidence suggests this antioxidant, maybe 400 milligrams a day, might help smell loss after a viral URI, but good quality controlled trials are needed. It's also been suggested for some taste loss and burning mouth syndrome. Zinc and vitamin A. Their use for general smell problems is considered controversial. There's little evidence they help unless someone has a documented deficiency. Zinc has shown benefit for taste problems related to liver disease, though. And vitamin A derivatives, retinoids, are known to be important for olfactory neuron survival. One protocol using zinc infusion with chemo suggested possible protection against taste damage, but needs more study.
Other vitamins.
Vitamin B12 deficiency from poor absorption could theoretically contribute to nerve issues, including olfactory nerves, but it's not a common primary cause. Vitamin B2, riboflavin, and magnesium are sometimes mentioned in alternative literature for migraine management, and migraine can be linked to smell issues, so that's an indirect connection. And vitamin D deficiency has been linked as a cofactor in chemo-induced smell taste problems, suggesting ensuring adequate levels might be helpful for those patients.
Are other medications ever used off-label to try and treat symptoms like distortions, even if the evidence is weak?
Yes, the source mentioned several that have been tried, often for bothersome dysosmias or phantosmias, especially after head trauma. The Ophion, an asthma drug, was reported in one uncontrolled study, but the results were questionable due to lack of controls and similarity to spontaneous recovery rates. Certain antiepileptics and some antidepressants, like amitriptyline, are sometimes used for these distortions. But ironically, amitriptyline itself is known to cause smell-taste problems in some people, possibly due to its anticholinergic effects. So it's complex.
Hmm.
Dunpiesel, the Alzheimer's drug, showed improved smell identification in one study of AD patients, correlating with other dementia scores, hinting at a cholinergic link.
What about alternative therapies?
Things like acupuncture, meditation, cognitive behavioral therapy, CBT, and yoga are mentioned. Not necessarily as cures, but as potentially helpful ways for patients to manage the discomfort and stress associated with persistent chemosensory problems or oral pain and to cope with the psychosocial impact.
And lifestyle changes. Diet.
Definitely important. Modifying the diet and eating habits can help. Consciously focusing on other sensory aspects of food, its texture, temperature, visual appeal, even its external aroma before eating, orthonasal smell, can enhance the overall experience when taste or retronasal smell is impaired. Using flavor enhancers like MSG or extracts might help sometimes, but with a big caution. Avoid just dumping on extra salt or sugar, especially for people with hypertension or diabetes.
And preventative measures.
Absolutely key. Good oral hygiene, regular dental care, and good nasal hygiene can prevent local infections or inflammation that cause problems. And the source strongly reiterates, smoking cessation and stopping any oral tobacco use are essential for anyone with smell or taste issues and should be emphasized repeatedly.
And finally, bringing it full circle, you mentioned testing itself can be therapeutic. Remind us how.
It's about validation and perspective. Getting that objective confirmation of a loss validates the patient's experience, especially if they felt dismissed. Knowing the loss is real can reduce anxiety. If the loss is mild, the test result allows for more positive prognosis, offering hope. And for older individuals, learning their function is actually normal for their age provides crucial perspective, countering feelings of hopelessness or fear of serious illness, and improving self-esteem. It empowers them with accurate information.
We've certainly taken a deep journey today, from the hidden, intricate anatomy and pathways of smell and taste, through that incredibly long and diverse list of ways they can be disrupted: infections, trauma, systemic diseases, neurodegeneration, medications, even pregnancy.
It's a lot.
We explored how clinicians approach diagnosis using history, exams, and that crucial objective testing. And finally, looked at management, acknowledging successes, but also the very real limitations.
And it's just so clear from digging into this source material how incredibly intricate these senses are, how widely connected they are throughout the body, especially those extraoral taste receptors. Just fascinating. And how vital they are to our health, our safety, our well-being. They're crucial monitors of our world, inside and out. And they profoundly shape our quality of life in ways we often only truly appreciate when they're gone or distorted.
Yeah, and here's where it gets really interesting, pushing our thinking forward, right?
Yeah.
Consider just how interconnected these senses are, not just with each other for flavor, but with metabolism, immunity, our core neurology, even our emotional lives and memories. They aren't just isolated inputs.
Which brings us to a really important question for the future, doesn't it? Given their role as potential early warning signs for huge diseases like Parkinson's and Alzheimer's, and their links to overall health indicators, even genetic susceptibility to infection, how might routine chemosensory screening, maybe just a quick smell test during a regular checkup, how might that change our whole approach to preventative medicine, to early disease detection, to monitoring health down the line?
It's a really thought-provoking possibility, stemming directly from the kind of detailed knowledge we've explored today from Chapter 33. What stands out most to you, our listener, from this deep dive? Thanks for joining us for this deep dive into the world of smell and taste disorders, drawing everything from our expert source material, aiming for that mastery-level understanding.
Until next time.